Welcome back to the discussion, Military Health and the Move from Legacy Systems, sponsored by Leidos on Federal News Radio 1500 AM and federalnewsradio.com. My guest today is Doug Barton, Senior Vice President, Chief Technology Officer, and Chief Engineer, Leidos Health. I'm your moderator, John Gilroy. All kinds of challenges when you move from one big system to another big system. Just real quickly here, maybe 3 or 4 of the big challenges in this big change for you, Doug.
Well, first and foremost, technically, there was a question of scale. And 9.6 million beneficiaries leads to a very, very large system. There's 150,000 roughly MHS employees, doctors, nurses, administrators that manage that system. When you bring in Guard and Reserve, that number grows by another 50,000. So there's a very large number of users, and there's a very large number of beneficiaries. In addition, in the current system, there's roughly 3 million ambulatory encounters a month and roughly 35 to 40,000 inpatient encounters a month. So it's a very, very large system. Generally speaking, if you look at commercial implementations of similar scale, like Kaiser, they break the system up into multiple pieces because there isn't, in fact, continuity of care absolutely required except through data interchange between somebody that's getting care in Northern California and somebody that's getting care in Southern California. People don't move around quite as much. In the Department of Defense, however, you're changing location, PCSing as they say, every 3 years. And so you can be anywhere in the world that the DoD has, forces deployed. Therefore, your record needs to move with you and be constantly available. That drove us to an architecture that has a single instance for the entire department in a single location where the data is already integrated by definition. And therefore, when you scale that up to what they call full operational capability, which will be a number of years in the future, you've got a very, very big system. If you combine that by taking a commercial product and adding some of the additional cybersecurity requirements that are not to commercial standard but are to DoD standards, some of those do in fact have system performance and system flexibility ramifications. So you've got a little bit of headwind there on the performance side that also needs to be managed. So it was a very challenging implementation. The system's live at the first 4 sites. They call that initial operational capability. It's up in the Pacific Northwest. The first site went live in February of 2017. We're now in an acquisition process called operational test and evaluation, which would lead to a full deployment decision, which is an acquisition milestone decision in May of this year. So I think we've worked through those challenges. As we move into the future, when we really start to scale up, we'll have to keep a very careful eye on how that scale impacts current performance.
Legacy systems have important information, and when you talk to software developers, they cringe when you talk about data extraction and conversion, but this is part of the process, isn't it? Because there's existing data has to be pulled into the new system.
Indeed, and once again, the department recognized that prior to award as part of their acquisition strategy, and they did several things that were unusual and frankly, in my view, very, very smart. Number one, they established a sister program called DMIX, and roughly 1.5 to 2 years before DIMSUM was even awarded, DMIX was in the process of working with the legacy systems to create infrastructure to provide that data in a consumable form to DMIX when it came online. So they got a 2-year jump, as it were, on the challenges of taking that legacy data, understanding where it sits, getting it rationalized, and making it available. That's number one. Number two, at the point of IOC, the plan was working with the clinical community to select those data that were clinically most crucial and only in the first order bringing those data elements into the new system. So as opposed to bringing the entire record over, which can be quite challenging, they brought over what's colloquially called the PAMFI data, procedures, problem list, allergies, medications, and immunizations. That data is required on a patient safety and clinical care basis to be made available. There's future plans to manage the rest of that data, but the combination of giving another program a head start on a very hard problem, number one, and number two, being thoughtful about how much data they needed to migrate at IOC to provide clinical care, made that problem much more manageable. and frankly didn't have the effect that legacy migration has on almost every other such system I've worked with, which is significant delivery delays.
Yeah.
We delivered on schedule, or very close to on schedule.
So you have a large system, you have to bring in previous information. A large system, you have to interop with other systems as well, and everything's changing. This is a moving target.
Well, as you can read in the news, interoperability in healthcare more broadly is a significant challenge. What we have is a commercial system that works to the state of the practice. So if it's within the bounds of current commercial practice, and if you're in the business, you'll know about the direct protocol, what used to be the connect protocol for information exchange, the primary data standards, which are HL7, the CCDA, or Consolidated Clinical Document Architecture formats, FHIR, which is Fast Health Interoperability Resources. All those basically come integrated into the product because they're part of the commercial standards that are out there. Even more so, e-prescribing interfaces are already built in. So if I need to send it to CVS at the corner, that's already built in. If you need to send it out to Quest for a laboratory, that's called reference labs. Those protocols are built in. Public health reporting's built in. So we had a leg up. Then the challenge was for those DoD unique business systems, most especially the Master Patient Index, which is called DEERS. Those were simply integrations, which frankly were challenging. But if you reduce the scope of your problem just to the DoD-specific elements, you've got a manageable situation.
We are going to pause here for a short break. My guest today is Doug Barton, Senior Vice President, Chief Technology Officer, and Chief Engineer, Leidos Health. I'm your moderator, John Gilroy, on the discussion, Military Health and the Move from Legacy Systems, sponsored by Leidos on Federal News Radio 1500 AM and federalnewsradio.com.